So, what really happens when a person in a suicidal crisis walks into a hospital or an urgent care clinic? Well, you might imagine a lot of things, but what you might not see is a hidden system that clicks into gear. This isn't about guesswork or just hoping for the best. Nope, it's a series of systematic, evidence-based steps designed to find the risk, create safety, and build a bridge to a better future. Okay, let's dive in and uncover this life-saving process that so often goes unseen.
It all starts with a number, and it's a pretty stark one, 1 in 10.
And that's what this number means. For every 10 people sitting in an ER or urgent care waiting room, for anything, a broken arm, the flu, you name it, one of them might be silently carrying the crushing weight of suicidal thoughts. That's the real scale of the invisible emergency that healthcare providers are up against every single day.
So here's our game plan. We're going to follow a patient's journey through this entire hidden system. We'll kick things off with how this invisible risk gets spotted in the first place. Then we'll look at the very specific questions they use to screen for it and how doctors figure out the true level of danger. From there, we'll see how a modern safety plan is built, what happens in that crucial first week after someone leaves the hospital, and finally, we'll zoom out to see the huge system-wide mission that ties it all together: zero suicide.
You see, the first big hurdle is that this emergency doesn't always announce itself. It's often invisible. Without a proactive system in place, so many at-risk people would just get their physical problem treated, get sent home, and that underlying crisis would be completely missed. And this chart really shows you the heart of the problem. If a patient comes in for a behavioral health issue, screening for suicide risk is 100% mandatory. That's that first bar. But the really critical part, it's that second bar. Up to 10% of patients who are there for totally different medical reasons are also at risk. And that is exactly why so many health systems now do universal screening. They ask everyone, because it's the only way to find those who are suffering in silence.
Okay, so once a system decides to look for this risk, how do they actually do it safely and effectively? Well, it's not about just asking random questions. It's about using precise, evidence-based tools that have been scientifically tested and proven to work.
And this isn't just a good idea. It's a national patient safety goal. The Joint Commission, the organization that accredits hospitals all over the country, actually mandates this kind of screening. Their involvement just goes to show you that spotting suicide risk is considered just as fundamental to patient safety as, say, preventing infections in the OR.
And this is a great look at the tools of the trade. These are not long, complicated psychological deep dives. They're super efficient instruments, built for a fast-paced environment like the ER. I mean, look at the ASQ. Just 20 seconds to ask a few direct, proven questions. Or the CSSRS, which is kind of the gold standard, uses plain English to get clear answers in less than 2 minutes. This is science, not just conversation.
And this is why that scientific approach is so critical. You can't just make up questions on the fly no matter how good your intentions are. Accrediting bodies warn against these homegrown tools because they just haven't been tested. They might not be reliable or valid. And in a situation this serious, that very first step has to be the right one.
Okay, so a screening tool raises a flag. A patient is identified as being at risk, but that's really just the alarm bell ringing. It's not the full story. A positive screen is just the beginning. It kicks off a much deeper, more nuanced clinical assessment to figure out the true nature of the danger.
And this is where things get really subtle. A clinician has to weigh two different things: subjective intent versus objective lethality. Basically, subjective intent is how intensely the person feels they want to die. Objective lethality is how medically deadly their plan actually is. You could have someone with incredibly high intent who plans to overdose on something harmless. On the flip side, you could have someone with lower intent who has a plan that is extremely lethal. Both need immediate help, but the approach will be tailored.
As soon as high risk is confirmed, the immediate environment has to be secured. And this is a systematic process. Staff will create what's often called a safe room. They'll remove anything that could be used for self-harm, and we're talking about more than just the obvious stuff like belts or shoelaces. They look at door hinges, hooks, cords, even bedding. The entire physical space is basically transformed into a protective bubble.
Now, what about patients who are deemed safe enough to be discharged? Well, the goal is to build a solid bridge from that moment of crisis to a safer future. And that's where the modern, collaborative safety plan comes in. It is a massive step up from outdated things like the old no-suicide contracts.
And let's be super clear here. A safety plan is not a contract. It's not some piece of paper a patient is forced to sign promising they won't hurt themselves. We know those don't work. Instead, this is a tool that is created with the patient. It's their personal, written guide,
filled with their own coping strategies and their own support system, ready for them to use if a crisis hits again. It's all about collaboration, not coercion.
So what does it actually look like? This is the evidence-based Stanley Brown safety plan, and you can see how it builds a safety net in layers. Step 1, help the person identify their own personal warning signs. Step 2, figure out things they can do by themselves to cope. If that's not enough, Step 3 is about using social settings as a distraction. Step 4 is about reaching out to specific people for help. Step 5 is having professional numbers ready to go. And crucially, Step 6 is about making their home environment safer.
Creating that plan is a huge step, for sure, but the journey is not over when the patient walks out the door. That period right after discharge is incredibly vulnerable, and the system has very specific strategies to bridge this dangerous gap in care.
I mean, this timeline really says it all, doesn't it? That first week, days 1 through 7 after discharge, that is the highest risk window. The danger is at its absolute peak. And even a month out, the risk is still way higher than normal. This is exactly why simply handing someone a list of phone numbers and wishing them good luck just isn't the standard of care anymore.
So, how do you bridge that gap? One of the most important tools is something called a warm handoff. This replaces the old cold referral, where a patient just gets a list of names to call. A warm handoff means the hospital staff actually schedules that first outpatient appointment for the patient right then and there, usually for sometime in the next day or two. It takes the burden off the patient and guarantees a direct connection to ongoing care.
And the second tool sounds almost deceptively simple, but the research shows it's incredibly powerful. It's called caring contacts. These are just brief, supportive, non-demanding messages, a text, an email, even a postcard, sent to the patient after they go home. They don't ask for anything. They just say, hey, we're thinking of you, and we're here for you. And that simple act of connection has been shown to significantly reduce suicide attempts just by reminding someone they haven't been forgotten.
So, up to now, we've really been following the journey of one individual patient. But let's zoom out for a second. What's the philosophy that makes this entire systematic process possible? Well, it's a huge cultural shift in healthcare that's changing the game.
It's called the Zero Suicide Framework, and it's championed by major organizations like the Education Development Center and the Suicide Prevention Resource Center. Zero suicide isn't just a program or a catchy slogan. It's a system-wide commitment. It's basically a declaration that suicide deaths for patients who are under the care of health systems are preventable. And this is the roadmap for how they do it. The whole framework is built on these 7 core parts. It has to start at the very top, with leadership committing to the goal. It means training the entire workforce, not just the doctors. It requires systematically identifying the risk, which we've talked about, and then engaging patients, using proven treatments, ensuring safe transitions, and finally, using data to constantly get better. It's the whole shebang. And in the end, everything we've talked about today comes back to this one single powerful idea. This is the core belief that drives the whole system. It reframes suicide not as something that's inevitable for some people, but as a preventable outcome, as a system failure that we can fix with better, more systematic care. It's a message of responsibility, and ultimately, it's a message of hope.
And that leaves us with one final thought to chew on. This whole system isn't about trying to predict who's going to die. It's about building systems to prevent it for everyone who's at risk. So the big question is, how could that shift in thinking, moving from a culture of prediction to a culture of prevention, transform other areas of healthcare, and maybe even society as a whole?